So good afternoon, dear colleagues, experts in cardiovascular prevention, ladies and gentlemen. It's my pleasure today to welcome you to the lecture and discussion, both dedicated to cardiovascular prevention. This event is organized by the Lithuanian Heart Association together with Vilnius University Hospital Santaros Klinikos and company Orkla Care. Today we will have the leading expert in omega-3 fatty acid research, Professor William S. Harris. I would like to acknowledge that Professor William S. Harris is a professor at University of South Dakota Sanford School of Medicine. He is an author and co-author of more than 360 publications. Professor's friendship with a research lasts for 40 years now. And Professor William S. Harris is a co-inventor of the Omega-3 index blood test. We are eager today to hear his lecture named Omega-3 and Health, Recent Research and Trends. So please, Professor, the stage is yours.
Well, thank you all. Thank you for the kind introduction, and I appreciate the opportunity to not only speak here, but along with my wife, come to Lithuania for the first time. It's been a wonderful time. We've had 2 or 3 days to visit, and love this unexpected little jewel here. So we've had a nice time. Excuse me. So yeah, we're going to talk about omega-3 and health in a rather large scope. Part of it cardiovascular health, part of it prenatal health, part of it brain health. So it's quite a widespread of things that the omega-3s seem to affect. So we'll begin with our outline. What are omega-3 fatty acids? It's important to define them because there is some confusion about that. Let's make sure I hit the right one. Where do we get them in our diet? We'll talk a little bit about the omega-3 index, which is, again, a blood test that we developed some years ago. How to improve it, how much omega-3 should we consume to have healthy levels, and then we get into cardiovascular, brain, some emotional health, and some vision issues. So we'll cover quite a bit of territory on the omega-3 scale here. First of all, what are omega-3 fatty acids? This slide shows what we'll call the parent omega-3 fatty acid. This is it's called alpha-linolenic acid. It's the structure here is 18 carbon, so it's an 18 carbon chain. There are 3 double bonds in the molecule, so 1, 2, 3, and the first double bond is in the 3rd position from the terminal carbon. So this is called the omega carbon, that's called the alpha carbon. So the omega carbon, if you count back 3 positions, omega minus 3, that is what is common to all omega-3 fatty acids, that structure. But this particular fatty acid, which is found in certain plant oils, plant seed oils, is not really the omega-3 that has all the benefits. This can be made into the long-chain omega-3s with some difficulty. So really, these are not a substitute for these, what we'll call the marine omega-3s, the omega-3 fatty acids you find in marine animals. So the two that, when I speak of omega-3, I'm really talking about EPA and DHA. EPA stands for Eicosa pentaenoic acid. Eicosa means 20, and penta means 5 double bonds. So it's a 20 carbon, 5 double bond molecule. Thankfully, we just call it EPA. DHA is the next one. It's a 20 docosa hexaenoic acid, DHA, 22 carbons, 6 double bonds. So the these two together, always found in fish oils, cod liver oil, certain oils derived from certain algae will have these. This we would call an essential fatty acid because it cannot be synthesized in the body from simple precursors. These two fatty acids we would call conditionally essential, meaning that we don't make enough of these from this. You can make some, but we don't really make enough for optimum health. So to get optimal health, you really need to take these directly in the diet. And again, our daily, at least in the United States, the typical intake of these two is about 150 milligrams a day. Contrast that with Japan, a country that eats a lot of fish. They would probably consume about 1,000 milligrams a day of EPA and DHA. Okay, so when I talk about omega-3, I'm talking about these two here. Yeah, we're not going to go through this slide in detail, thankfully, but this was published some years ago, and it outlines some of the mechanisms of action for omega-3. And if we start over here in the larger scale, the omega-3s are known to lower triglycerides. That's one of the things that we discovered early on in omega-3 research. They also will affect heart rate by affecting the autonomic nervous system, and therefore reduce risk for arrhythmias. They have an effect on blood pressure, and lowering blood pressure by causing the vasculature to dilate. And in thrombosis, the omega-3s can make platelets less likely to coagulate, to aggregate, reducing risk for clots or thrombotic effects. So that's kind of a global look. If you look at the cell membrane, the omega-3s are found in the cell membrane. So here is the outer layer of phospholipids. This is the inner layer of phospholipids. And EPA and DHA, when they're present in our diet, will be found in this membrane. And it's their presence in the membrane that really affects much of their activity because they are very long chain and they're very crooked. They're very fluid. They change the fluidity of the membrane so that proteins, ion channels, transporters that go through the membrane behave differently when they're in the environment of a membrane that's rich in omega-3 compared to normal. So their signaling is affected. Certainly the omega-3s can be released and converted into a variety of prostaglandins and leukotrienes, other oxygenated metabolites that have important effects on the cell. And ultimately, the omega-3s can actually affect DNA transcription and the production of different proteins from DNA. So that's a very high overlook of how omega-3s work. They work at very deep levels of metabolism. They don't just do one thing. So in that sense, they're not like a drug, which has one target and one effect. These affect many systems across the body because they're part of every cell membrane. Yeah, I mentioned that the omega-3s are important for production of what we call oxylipins. This is the large family of molecules that are basically oxygenated fatty acids. And among those, we see, where's the standard? Prostaglandins are the ones most people are aware of, but EPA can be made can be made into prostaglandins as well as thromboxanes, leukotrienes, a series of molecules called resolvins, which are fairly newly discovered. These are the different enzymes that control the production of these molecules. If they're in green, they're anti-inflammatory, anti-aggregatory, vasodilators. On this side, DHA, the other omega-3, can be made into a variety of different molecules as well, including endocannabinoid receptors. EPA and DHA can also serve to activate these receptors. So there's a tremendous amount of biochemistry buried in the omega-3 story that's just really now becoming appreciated. So the best sources of omega-3. I took this slide off the internet, and then I had to fix it because those are not good sources of omega-3. This is a common confusion when people will say things like this, and then they'll include spinach and different kinds of seeds and soybeans and broccoli, which has no omega-3 at all. Even the plant omega-3 is not here. So people make a lot of mistakes. Really, the sources of omega-3 that are important are things that come from the sea. Sometimes eggs. If the chickens are fed omega-3, the eggs can be higher in omega-3. Cod liver oil is an example of a classic omega-3 product. But oily fish, sardines, herring, salmon are all good sources of omega-3, EPA and DHA. But the plant sources are not, should not be confused. So you've seen dietary supplement bottles everywhere. I put this up here just to kind of point out that if you really want to understand how much omega-3 you're getting from one of these supplements, you need to look at the supplement facts panel here. Because here it says you're getting about, it says omega-3, 2,250 milligrams of omega-3. Well, okay, about 2,100 milligrams is EPA and DHA. But that 2,100, it says here a serving size is 3 pills. So that 2,100 is really 700 per pill. It's important to realize, I mean, they can put a serving size is 5, and you get it looks like you get a huge amount of omega-3, but you actually have to take 5 pills to get it. It's best if you can buy products that have the serving size is 1 pill, and you can get maybe 1,000 milligrams of omega-3 through it. But the important thing is, as you're trying to decide how much, which products to buy, look for the amount of omega-3 per serving and see what a serving is. Certainly for cod liver oil, a classic serving is 1 teaspoon, 5 milliliters. And that's got about 1,000 milligrams per teaspoon. I just put this up here because I want to be aware of products that are total omega, that they just, this is totally marketing is what this is. This is not science. Because these capsules provide omega-3, omega-6, and omega-9, different families of fatty acids. There's no need for us to eat any more. We get plenty of omega-6 in our diet as it is, and omega-9 are not even essential fatty acids. We make these. We can make these de novo. So there's no need to ever buy a product that includes other omegas. The problem is we haven't got enough omega-3 in our diet. The others we have plenty of. And the other problem with this product is you really can't tell how much of this is EPA and DHA, because one of the ingredients, although fish oil is one ingredient, the second ingredient is flaxseed oil. So flaxseed oil provides the plant omega-3. So a large part of this might just be alpha-linolenic acid, the omega-3 from plants, which is, as far as we know, not nearly as beneficial as EPA and DHA. So this is a product not to buy. Okay? I'll also note that there are different forms of omega-3 fatty acids. They can come as ethyl esters, which is the pharmaceutical form of omega-3. This is a form that allows a pharmaceutical company to concentrate a high amount of omega-3 in one capsule. Triglycerides is the more natural form, where omega-3s are 1 or 2 or 3 of the fatty acids in a triglyceride molecule. And so this one has a mixture of the two. And we'll see more of them later. Okay, just to step aside for a moment, there's certainly a lot of interest in the Mediterranean diet. And the Mediterranean diet, we know as a diet pattern is very heart healthy, but exactly which components of it are heart healthy is not all that clear. People often equate the Mediterranean diet with essentially olive oil. And certainly olive oil is a part of the Mediterranean diet. But there's also what you might call a Mediterranean lifestyle, which contributes to, I think, the reduced risk for heart disease in countries around the Mediterranean. The diet is just a part of the lifestyle, and olive oil is just a part of the diet, and oleic acid, which is the primary fatty acid in olive oil, is just one of the components of olive oil. So people have assumed that the benefit of the Mediterranean diet is because of the oleic acid that's in the olive oil, that's in the diet, that's in the lifestyle, which is it's a grand assumption, but that's not a lot of evidence for that. In fact, I should also point out because this is, of course, a plant oil, it has no EPA or DHA in it, in olive oil. I did see this paper just published last year looking at the question of oleic acid. Oleic acid is an omega-9 fatty acid. It's not an essential fatty acid. It's the most common fatty acid in our diet, typically. Most things have it. So this is a study that looked at the association between plasma levels of oleic acid and their association with risk for cardiovascular disease. And so this study had about 6,600 people that had plasma fatty acids measured at baseline. And then they followed them over 13 years for different events, particularly risk for cardiovascular disease. And interestingly, they found that the people with the highest levels of oleic acid in the blood had a higher risk for cardiovascular disease than people with the lowest levels of oleic acid. So this is part of the confusion, I think, around olive oil and its benefits when the principal component of olive oil, oleic acid, low levels look to be protective, high levels are not protective. So we have, I think, a lot to learn yet about the importance of oleic acid and olive oil in cardiovascular protection. I have a couple of videos in here that I hope will be interesting. This is about how real men get their omega-3s. They don't get them from a bottle of dietary supplements. They actually go out. Okay, a little humor. Very little, perhaps. Anyway, this commercial never actually ran on TV. Okay. So I mentioned the omega-3 index. This is a biomarker and a risk factor. It's a test that we developed 15 years ago because we were interested in, we realized that omega-3 levels in the blood were actually risk factors in the same sense that cholesterol is a risk factor, except it's reversed. A higher omega-3 is good, like a low cholesterol is good, but it's the same idea. It's an independent risk factor. We measure the omega-3 index in red blood cell membranes. We are able to, with our technology, determine what the EPA and DHA content of the membrane is. So in this particular case, we really can't tell, but typically about 4% of the fatty acids in the membrane are EPA or DHA in the U.S. or other countries, Western countries that don't eat much fish. In a place like Japan, there are twice as many. Their omega-3 index might be 9 or 10%. We think that a level between 8 and 12% is the level that's associated with the best health outcomes. So we set that as our target for people to try to get their omega-3 level in the optimal health zone. Early on, we looked in when we first developed the test, we wanted to know, do red blood cells actually reflect the omega-3 content of other tissues, particularly the heart? Because at that time, cardiovascular disease was the primary focus of omega-3 research. And so we did this study in patients, actually these are heart transplant patients. We were able to get EPA and DHA levels actually in biopsies of the heart, of the right side of the heart. And we measured those, and we measured the red blood cell in the same patients, and we found that there was a nice correlation, not perfect, but a good correlation between the red blood cell and the heart. Other people have done this since and found that it's true that the red cell, as a circulating cell with a membrane, does reflect the membrane composition of other cells. The only exception really would be brain, where the omega-3 content is more regulated than it is in other tissues. Another feature of the omega-3 index is that it is, because we measure it in red blood cell membranes, it's much more stable within a person over time, as opposed to being moves around. Like, so in this particular study, we had 20 healthy volunteers, and we just drew blood from them once a week for 6 weeks. And we were just looking to, and we told them, don't change anything, just live your life normally. And we measured their plasma omega-3 levels. This is each line is an individual. And then we measured the red blood cell, EPA and DHA. And it's clear that red cell levels are much more steady within people, very much like hemoglobin A1C is used instead of plasma glucose for diabetics or for monitoring glycemic status. It's a long-term stable marker of omega-3 levels. The fact that the red cell, the within-person variability was 4%, and in plasma was 16%. So this is 16%. So it's about 1/4 the noise that you get in a plasma level. So we prefer red cells as a marker of long-term status. So these are results from 2 studies that did not come from our laboratory, but were the reason that we invented the omega-3 index was because of these 2 studies. And both of these studies asked the question, is there a relationship between red blood cell omega-3 levels and risk for either primary cardiac arrest in one study, sudden cardiac death in the other study? Those were the 2 endpoints they were looking at. And this study here was done in Seattle, published in the mid-1990s. It's a cross-sectional study. This study was done by actually working with the ambulance companies and the paramedic companies in Seattle, Washington, and having them draw blood from any person that they were emergently called to take care of somebody who was having a sudden cardiac arrest. So people who were actually having sudden cardiac arrest at the time had their blood drawn and saved for this study. And after about 6 years, they had enough blood samples, enough people in the study to ask the question, was there a relationship between their odds of being a person having a heart attack and the omega-3 level? And they found that compared to people who had the lowest quartile, so they took the population and split it into quartiles, the people with the lowest quartile of the omega-3 index compared to the highest, actually the people in the highest had about 90% less likely to be a case in this study. So case control study, you can only look at odds of being a case. You can't really look at risk per se. But there was certainly something about people who had a high omega-3 level that kept them from actually having a sudden cardiac arrest. So this was cross-sectional. That's not the best study design. Better is a prospective design where blood is drawn from people when they're healthy, not when they're having a heart attack, but they're drawn when they're healthy, ostensibly healthy. And then we wait over years to see who develops heart disease. And this is from the Physicians' Health Study, published in the New England Journal in 2002. And they got virtually the same answer as this cross-sectional study. The people in the highest omega-3 quartile were 90% less likely over a period of 17 years of follow-up to have a fatal coronary event, a primary cardiac arrest. So both of these studies said the same thing. Having a high omega-3 level was at least associated with significantly reduced risk for primary cardiac arrest, sudden cardiac death. And it was these two studies that really turned the light on for me and a colleague. I have a cardiologist friend in Munich, Clemens von Schacke, and he and I were sitting together at the American Heart Association meeting after this study had just been presented. And we said to ourselves, somebody ought to measure omega-3 levels. They mean something. They actually give you information about risk. It's not just a marker of how much fish someone eats, which is how they used to be used. And it ought to be a test that's available to the medical community so they can use it to manage patients. If you care about lowering cholesterol in your patient, maybe you should care about raising the omega-3 because they're in a similar category as risk factors. So he and I both got excited about this. We took a couple years. We wrote a paper. We defined the omega-3 index as a risk marker and kind of put it on the map in 2004, 2 years after this. So this was the beginning of my interest in omega-3 biomarkers. Okay. I was talking about sudden death. Here's our second and final video about a high omega-3 intake does not guarantee protection from sudden death. Okay, you can laugh. That's okay. It's cute. All right. I mentioned that we developed the concept of the omega-3 index in 2004. In the paper that we published, we had to come up with a target. What if you're going to have a risk factor like cholesterol, you have to have a target value that's healthy, that one can titrate or move the patient toward that healthy level. So we had to come up with a number, and based on the evidence that was available at that time, really up to the early 2000s, we either measured or estimated what the omega-3 index was in several studies, and what was the omega-3 index associated with the best cardiovascular protection. And all these different studies were involved with that versus the least. And we found that if you just take the average of all these estimated values, you get 8%. So we said, well, it looks like 8% is a reasonable target, at least to start for the omega-3 index. And I don't know why this is going a little too fast. So we said under 4% looks like a place you don't want to be. In the middle is kind of intermediate, and then over 8% is the perhaps optimal, cardiovascular optimal. We expect that this number will probably change as more research goes on, much like cholesterol targets have changed over the years. But we think this is a good one for now. We had the opportunity here last year, a couple years ago, to do a meta-analysis. Now there is enough data to look at the omega-3 index as a predictor of risk for fatal coronary disease. We had 27,000 subjects, 10 studies worldwide where omega-3 levels were measured in the blood, and then risk for fatal coronary disease was the outcome. And we were able to determine from this, I think, more realistic version that compared to people with low or relatively normal omega-3 index levels, those up at 8% were 35% less likely to die of cardiovascular disease. So this is a 35% reduction in risk from optimizing one risk factor out of many seems realistic to me. The idea that a high omega-3 will protect you 90%, give you 90% lower risk seems a little high, seems a little ridiculously high. 35% makes sense. And I think in view of the fact that there are many risk factors for heart disease, just correcting one of them could have this much impact is important. We've also looked beyond heart disease in our research anyway, asking the question here, what's the risk for death from any cause? So this is a study that looked at in a cohort called the Women's Health Initiative Memory Study. This is a study that we had about 6,500 postmenopausal women. We measured their omega-3 index at age 70, average age 70, and then we followed them for about 15 years for death from any cause, okay, not just cardiovascular. And we found that compared to women who had the lowest an omega-3 index under 4%, those who had an omega-3 index over 8% were 31% less likely to die in that 15-year period than these women. So and it wasn't just cardiovascular disease. There were other causes of death that were also reduced by having associated with a low omega-3. We feel like this was, again, further confirmation that an 8% target is least reasonable to aim for. We asked the same question in a different cohort. That cohort was all women, postmenopausal women. This one was in the Framingham study, the Framingham Offspring study, a major epidemiologic study from Boston. And we found in this study, and this was fewer people, 2,500 people who were free of cardiovascular disease when we collected their blood. They were 66 years old on average at the time their blood was collected. And they were followed for a little over 7 years. And so between age 66 and roughly 73, a certain number of people in this cohort died. And so the question was, did the omega-3 index predict their risk for death? And again, in a large multivariable model. And we found that's true. This is now looking at just quintiles of the omega-3 index. Lowest quintile, highest quintile. And as you can see, the spread is not that great, 4.2, 6.8, because this population didn't have very high omega-3 levels. So the spread is not, we didn't have people like from Japan in this study who have indexes of 8 and 12%. But nevertheless, even across this spectrum, there was a statistically significant trend for reduced risk for death from any cause as a function of the omega-3, higher omega-3, lower risk. We also looked at cholesterol in the same study and used the same statistical model with all the different covariates of that model. And we found that cholesterol levels measured at the same time the omega-3 was measured were not predictive of risk for death over the next 7 years. So they were not, the cholesterol was not useful in terms of predicting risk for death from any cause. Omega-3 was. So it's this kind of data that makes me think, and I've kind of always believed this, that omega-3 levels may be at least as important as cholesterol. I mean, it's not to say cholesterol is not important. It certainly is important to measure it. But if you think cholesterol is important, you probably ought to think that omega-3 is important as well, because they have perhaps more information. I mentioned Japan before. Again, here's the omega-3 index scale. Typical Europe and US. We don't know in Lithuania what the omega-3 index is. We'll see that in a moment. Typical levels for Japan, up here 8 to 12%. The Japanese have heart disease rates that are roughly about 1/10 of what we have in the US. I can't say that's all because of omega-3, but we do know the Japanese smoke more than Americans smoke. They have higher blood pressure on average than Americans have. They have higher stress levels, well, outside of politics, okay. They have higher stress levels than we have in America. So there's 3 factors working against them where you think they'd have more heart disease, but actually they have vastly less heart disease. They have more strokes, but they have less heart attacks. And I think one of the factors may be that they have a very high omega-3. And so it may be able to counteract all of those other factors. I mentioned Lithuania and Latvia as well. This is actually a graph of an estimate of the average omega-3 index around the world. This was not done by me. It was done by a colleague in Canada. And he took about 400 different data sets of omega-3 levels from different countries, 54 countries, 24,000 people, and from that information tried to paint a map. Red is, of course, the lowest levels of omega-3. Green is the best, highest, Alaska, Greenland, Norway, Japan, Korea. I don't know what's going on here. I'm surprised that there's any studies from these regions, but maybe there are. The red countries are, North America, of course, Brazil. Gray, as you see, most of the map is gray, including up here in Lithuania and Latvia, where we just don't have any data. So we don't know what the levels are. I'm guessing, given the fact that heart disease is not uncommon here, that it's probably pretty low. Reasons for low omega-3, it's pretty simple. You just don't eat it. It's not a complicated story. If you don't eat omega-3s, you don't get them in your blood. Again, supplement use is not widespread, omega-3 supplements. There's various different traditions. Norway has had a very old tradition of using cod liver oil, particularly early in life. So that's a good source of omega-3. Japan recommends up to 2.5 grams a day of omega-3. The U.S. and the WHO are very low, down to 250 milligrams a day. I think that's far too low to be beneficial, but it's better than the current 150 that's average in America. There are changes in our farmed fish now. We buy salmon, most of it's farmed. The levels of omega-3 are decreasing compared to 10, 20 years ago because omega-3 fatty acids have to be fed to farm salmon. They are really, they're essential nutrients for the salmon, so they have to have EPA and DHA in their diet. EPA and DHA are getting more and more expensive as the demand for omega-3 products goes up, and so there's pressure on, the prices go up for the fish oils that they put in the salmon feed. And so some manufacturers, some fish farmers are substituting vegetable oils for non-omega-3 vegetable oils for fish oils in the salmon feed, which is reducing the amount of omega-3 that's actually in salmon nowadays. So that's not a good sign. We need other approaches to feeding fish. And there can be effects of fish, of cooking methods. The microwaving, frying, canning can reduce omega-3 content. Eating boiled or raw fish, sushi is great, except usually when you eat sushi, you're not eating large amounts of fish. It's lots of small amounts. So all these things play together in affecting omega-3 levels. This is a graph we just published last year of a study we did in our laboratory looking at the question of how does the omega-3 index relate to fish intake and use of omega-3 supplements. And what we did was we had about 3,500 people. I don't have it up here. We had data from 3,500 people that had sent blood samples into our lab for analysis of the omega-3 index. And we asked everybody to report, so this is self-reported data, report how often they ate what we called oily fish. It's non-fried or baked fish, and how often during the week. And we also asked them if they took an omega-3 supplement or not, yes or no. And what we found was, if you just look at the blue columns, this is the group that reported not taking any supplements. No, they didn't take any fish oil. So as we go from not eating any fish per week to up to three times per week, of course, the omega-3 index corresponds very nicely with that reported fish intake. If there was no difference between this group and this group in the omega-3 index, I would be concerned that our test is useless. It's got to actually track with fish intake, and it did very nicely. But the average omega-3 index for people who didn't take supplements but ate fish 3 times a week or more was around 7%. So that's not quite there for the omega-3 index of 8. The red bars are for people who reported taking supplements and as a function of increasing fish intake. So what we find here is that the only group that actually exceeded the 8% on average for the group was the people that reported fish 3 times a week and taking a supplement. That seems like what it takes to have, on average, an omega-3 index over 8%. The American Heart Association has a goal or current recommendation that people should eat 1 to 2 fish meals a week. And that's as good as it gets, and they don't recommend supplementation. So what is the average omega-3 index of people who are actually following the American Heart Association guidelines? It's somewhere between 5 and 5, maybe 5.5, 1 to 2 fish meals a week. So the recommendations from the American Heart Association are not getting people where they need to be for optimum health risk reduction. So as I mentioned, actually 2018, 1 to 2 seafood meals a week is the recommendation, no recommendation for supplements. And so that's where they stand. Here is a commentary by Dr. Culler, who's a professor of epidemiology at University of Pittsburgh. And he responded to the publication of the new AHA guidelines, and he said, the Japanese consume about 1 gram a day of long-chain omega-3. Well, by the way, N3 and omega-3 is the same thing. Okay. PUFA is polyunsaturated fatty acids. So this is essentially omega-3s from fish oil. So they consume about 1 gram a day compared to 1 to 200 grams per day in the U.S. Plasma phospholipid measures of omega-3 levels are much higher in the Japanese than in the U.S. The key public health question is whether the recommended intake of seafood in the U.S. should be to reach the same level of omega-3 as in the blood in Japan, about 9% of total fatty acids versus 4% in the U.S. So I think this is a great point. Maybe recommendations for fish intake ought to be based on how much fish you should eat in order to get a protective blood level. That would be a rational approach to this. I'm not sure the American Heart's ever going to do that, but this is I like what he had to say about that. So how much omega-3 do we need? This was something we addressed in a paper we published this year, looking at, the title of the paper was Predicting the Effects of Supplemental EPA and DHA on the Omega-3 Index. So we're, again, trying to ask how much omega-3 do you need to get to omega-3 index of 8? The purpose was to develop a mathematical model you could use to predict the effects of a supplement on the omega-3 index. And this is simply just showing, we actually pooled data from 14 different studies we had done where we had measured the omega-3 index, and different doses of omega-3 were used, different durations of studies, different forms, some ethyl ester studies, some triglyceride-based studies, different kinds of patients. But at the end of the day, we used the data from this 1,800 people to come up with a model that looks like this. Looks like I got my line off a little bit. And what this figure is intended to show was how much EPA and DHA do you need to add to your diet, either supplements or fish, if you want to move from a baseline omega-3 index, which is shown down here, up to the target of 8%. And so the example here, this is supposed to be lined up with 4, but if you have a baseline omega-3 index of 4 and you go up here, you get roughly 1,500 milligrams a day of EPA and DHA is what it takes from these studies to get to a omega-3 index of 8. The reason that there's 2 lines is this is for triglyceride-based products, fish oils in the natural state, and this is for ethyl ester products. You actually need a higher dose because the ethyl esters are not absorbed as well. You seem to need a higher dose of the ethyl ester form to get the same change in the omega-3 index as the triglyceride form. So triglyceride is probably a better form for absorption. Okay, so we've talked a little bit about omega-3 and cardiovascular health, looking at those 2 epidemiologic studies. By way of perspective, I've recently been made aware of this data. I was not aware of it. This is Lithuania and Latvia. So what this is showing is the rates of death from coronary heart disease across the EU, data from 2016, Eurostat. You have the unlikely privilege of being number 1. You have apparently, from this data set, the worst death rate from heart disease of anybody else in Europe. And Latvia is second behind. Then we have Hungary, Slovakia, Romania, Chechnya, it's not, Czech Republic, thank you, right. Croatia, Estonia. It looks like a little bit of Soviet bloc happening here, but there seems to be a need. If these data are correct, then there certainly seems to be a need, particularly in this part of the world, to find ways to reduce risk for cardiovascular disease. And I'm sure your colleagues in the cardiology division know all about this and do everything they can to reduce risk. But again, omega-3 is one thing that's a very simple and safe and can be used on a population basis to reduce risk for cardiovascular disease in a population like this. So now I want to just talk about the effects of omega-3 on some cardiovascular risk factors. And we've already talked, and we'll talk more about on disease itself, but risk factors. So some of our earliest data, actually this is one of my most highly cited papers, as it turns out in hindsight. It was a review I did in 1989 on the effects of fish oil on lipid and lipoprotein metabolism in humans. And at that time, even at that time, 1989, there were 68 studies had been published with about 800 patients looking at the effects of fish oils in different types of hyperlipidemia. So we have normal lipidemic people, people with high cholesterol only, high cholesterol and high triglycerides, and people with isolated hypertriglyceridemia. So we were interested in different lipoprotein phenotypes. And this is the triglyceride effect. Really, in everybody, from normals to people with very high triglycerides, there was a 30 to 50% reduction in triglyceride levels given fish oils. And this was, again, evidence that was in the late 80s. So we've known that fish oils lower triglycerides for a long time. They tend to raise HDL cholesterol a little bit. They don't really do anything material to total cholesterol. This is an interesting thing in LDL cholesterol. Actually, in people that have this isolated hypertriglyceridemia, particularly very high triglycerides, levels that would be associated with risk for pancreatitis, for example. Very high triglyceride levels. These people get the biggest drop in triglycerides, but they also get a rise in LDL cholesterol. It's actually, the metabolism is the VLDL particles actually get converted quickly to the LDL particles, raises LDL. And there is some concern now that we have a study that was actually done with just EPA, this seems to be related to the DHA component of the fish oil. But it's also, I think it has to be pointed out that the effects of fish oils on LDL are, unless they're done in this very high risk, high triglyceride population, they don't affect LDL cholesterol. There is no reason to be concerned about giving fish oils and raising LDL, unless you're dealing, again, with people with triglycerides of 6 or 7 or 8 millimole. It doesn't happen in a more garden variety hypertriglyceridemia. Other risk factors that are affected by omega-3 fatty acids. Here is a study we did, again, in the Framingham population. Now we're just looking at the omega-3 index as it relates to, how is it related to different inflammatory markers. And we measured 10 or 12 different inflammatory markers circulating in the blood and found that this is the correlation between the omega-3 index. So if the value is negative, it means that the higher the omega-3 index, the lower the level of that inflammatory marker. And so across the board, all of these inflammatory markers were significantly reduced. Higher omega-3 was associated with a lower level. This is not an an intervention study. This is just an observational study. But there's other evidence that omega-3s do lower inflammation. But a higher omega-3 index is associated with lower overall inflammation in the body. More meta-analysis now. I showed you my data from 1989. This is 2018. People are still doing this, doing meta-analyses of the omega-3 effects on risk factors. And what they found here, the statistically significant effects were a slight increase in LDL, an increase in HDL. So both HDL and LDL go up. Your ratio doesn't change. Triglycerides went down significantly. This is the number of studies that were included. Blood pressure is actually reduced. Diastolic pressure significantly reduced. Heart rate is reduced. C-reactive protein is reduced. So they're all these things are better when omega-3 levels are higher. And what do we have here? Here's blood pressure. Again, this is a intervention studies looking here at, this is, I think, systolic. I think this is systolic and this is diastolic. And the overall effect of giving omega-3 is roughly a 5 millimeter mercury reduction in systolic pressure and about a 3 millimeter reduction in diastolic pressure across the board. So higher omega-3 levels do lower blood pressure. I wanted to point, there's a study published last year, a couple years ago actually now, looking at the effect of omega-3 supplementation on atherosclerosis. And so this is not events, this is actual imaging of the coronary arteries. 285 adults with known disease, everybody taking a statin. So statins were in the background of all of this. They were randomized to omega-3 acid ethyl ester. This is Omacor. They were given Omacor 4 grams a day, which gives you about 3.4 grams of EPA and DHA, versus no omega-3. 30-month trial, they looked at coronary artery plaque volume by CT scanning. And they found here, this is the omega-3 column, and this is the controls. About 100 people in each group, changed from baseline. And over here is statistical significance. This was a change in fibrous plaque was favorable. The omega-3s changed fibrous plaque in a more favorable way than did the placebo. Non-calcified and total plaque was a tendency toward reduced risk for atherosclerosis seen just in this 30-month trial of omega-3. The authors also measured the omega-3 levels, the omega-3 index, roughly, and they reported here that the plasma omega-3 levels achieved were a better predictor of outcome than the treatment allotment. So if you just measure who went up on their omega-3 level and who achieved a higher level versus lower level, in just about every case, fatty plaques, fibrous plaques, non-calcified plaques, calcified plaques, the people who had higher omega-3 levels, and they measured plasma phospholipid, which is a different numerical metric. This is probably more like 5% for an omega-3 index. But the omega-3 level in the blood was a better predictor of who benefited than who did not. So they concluded high-dose omega-3 ethyl esters provided additional benefit to statins in preventing progression of fibrous coronary plaque volume over 30 months compared to statin alone. In patients who adhered to treatment assignment and in the setting of a well-controlled LDL cholesterol, because they're all on statins. The benefit was not correlated with triglyceride reduction. And this point comes up more and more. We think the benefits of omega-3 probably are not related specifically to lowering triglycerides. Lowering triglycerides is one of the side effects, you might say, of taking omega-3, but that probably is not materially involved with the mechanism of reduction. So again, they need to look at more studies. Other studies have been done. Interestingly, in the same study, this is a study again with people with stable coronary disease, they also did questionnaires about physical function, just as long as they're giving all these people omega-3. So this is the effects of 1 year of treatment, again, about 300 heart patients with 3.4 grams of omega-3. And this is effects on physical function reported by. And there was a nearly significant reduction in reported risk for pain in joints in the people that got the omega-3s. Stiffness was significantly reduced. Physical function, as they had a global metric of physical function, that was reduced, as was this Western Ontario Arthritis Index, was markedly reduced. And this is one of the most common things we hear anecdotally about people who are taking omega-3. because their doctor said their triglycerides are too high. They gave them omega-3, and then they say, my shoulder doesn't hurt anymore. So you're seeing joint effects, even though that's not the target for the omega-3 fatty acids. This is also a fascinating finding. After 30 months, 11 patients had to have a knee or a hip replacement in the control group. Only one patient in the omega-3 group had to have replacement. And, so 11 versus 1, statistically significant. The authors of this study are now trying a new study focusing just on the effects on the need for joint replacement. And if omega-3 treatment, something as cheap as omega-3 treatment could actually reduce the need for joint replacement, it could be a huge financial benefit, of course, saving to the health system. Let me just skip that, I covered that. Kidney function was also studied in this study. Again, 3.4 grams of EPA and DHA. And they found that, at least in the diabetic patients, whether they're on diabetic drugs or not, the group that got Lovaza or Omicor had significantly less change in their ARC, kidney function, the albumin-creatinine ratio. So there was a benefit in kidney function as well in people that got omega-3 fatty acids, particularly in the diabetics. Non-diabetics, there wasn't much of an effect. Their conclusions: EPA and DHA supplementation attenuated the progression of albuminuria in subjects with type 2 diabetes and coronary artery disease, most of whom were on ACE inhibitors or ARBs. Supplementation could be considered as additive therapy to ACEs and ARBs in subjects with type 2 and coronary disease. So this is kind of a new indication that people are looking at. Let me skip that one, it's kind of complicated. I'll go on to this one. I think this is the most interesting. These are 3 studies that were published in 2018, actually published in 2019, but reported out in 2018, the effects of omega-3 in heart disease. And these are double-blind, placebo-controlled, randomized trials. One is called ASCEND. This is a study that was done in Great Britain at Oxford in diabetic patients only, omega-3 supplements versus placebo in diabetes. VITAL was the largest study ever done in omega-3. This was done in the United States. Omega-3 fatty acids and vitamin D for the prevention of cardiovascular disease and cancer was the target. And then REDUCE IT is a pharmaceutical study that looked at the effects of just EPA, high-dose EPA in patients with coronary disease. So we'll look at these studies, and here's where it gets kind of interesting, because if you just read the abstracts of 2 of these 3 studies, they're considered failures. But if you look at the data, and if you think about it for a minute, you can see that they were actually beneficial. So here, ASCEND, again, was a study in diabetics, randomized trial, 15,000 patients with diabetes, with no evidence of atherosclerotic cardiovascular disease. Here's a trick. Omega-3 fatty acid treatment, 1 gram a day, so it's 1 Omicor capsule was the treatment. So 840 milligrams of EPA and DHA. Not a big dose, but a common dose. Olive oil placebo, 1 gram. Compliance was the same in both groups. 7.5 years of follow-up in this trial. Their primary endpoint was a composite endpoint, and composite endpoints can be misleading, I think. So they called it serious vascular events was their primary endpoint, composite of non-fatal MI or stroke, TIA, or vascular death from cardiovascular disease. So those 4 things are the composite endpoint. If any one of those things happened to somebody in the trial, they were considered as having an event that counted in whatever group they were in. So their primary finding from the abstract, no significant difference in serious vascular events, with omega-3 treatment. And that, of course, is what the press reported and what the medical press as well reported. And so here, just a report from the ESC, omega-3 fatty failed to reduce cardiovascular events in diabetic patients. So that's, again, why people think omega-3s don't work. Well, if you actually think about, why I kind of expected failure. These are 63-year-old people. They're obese on average. 75% are on statins, 60% are on antihypertensive medicines. The omega-3 dose was quite low, 840 milligrams. So, okay, I wouldn't be surprised if they didn't work. Okay, that's not a surprise because that's a tough thing to turn around. But if you actually look at the data in the paper, here's their primary serious vascular events, and here's the point estimate and the confidence interval. It's a 0.97 with a non-significant confidence interval. So that's what they're talking about. There's no effect. But if you actually look among these different components of the primary event, vascular death was significantly reduced, 19%, and again, statistically significant. The fact that transient ischemic attacks were not affected, or non-fatal strokes and non-fatal MIs were not affected, does not mean that people did not die less of cardiovascular disease. So there was a significant benefit seen here, but because you summarize it in this metric, you can't see it. It's canceled. But it's not canceled in reality, it's only canceled in statistics. Okay. So there really was an effect of omega-3 in this trial, even that low dose, even in those patients, that should have been at least acknowledged by the authors, if not highlighted. Again, other fatal outcomes, they point out here, coronary disease, all strokes, other vascular disease, 18% reduction. So, and there was a tendency for all-cause reduction, but it wasn't significant. So again, it's how you present the data, how the press spins the data, and how the authors spin it. Despite negative conclusions from the authors, EPA and DHA significantly reduced risk for fatal vascular events in this study. I think this should be considered a successful, at least a component of this is a successful outcome, especially when you're talking about an intervention like omega-3, which is completely safe. It doesn't interact with anything. There's no side effects of any substance. The fact that you get any benefit at all should, when you balance it against safety, should say omega-3 should be used. You're not taking any risk at all in doing it. Let's look at the next study, VITAL. This was, again, the largest study. This study was 26,000 people, one of the largest trials ever done. It is the largest omega-3 trial. It included patients over 50 who had no history of coronary heart disease or cancer. So it's a primary prevention. So really the first primary prevention study in the omega-3 space. Everything else has been secondary prevention. Again, they used one capsule of Omicor, 840 milligrams, and this also looked at vitamin D as well in a 2x2 factorial design. Didn't find any effect of vitamin D, so we'll just, on heart disease, so we'll skip that. 5-year follow-up, again, a composite endpoint, primary cardiovascular events. Composite of MI, stroke, death from cardiovascular disease. So these three all went together in this study. Their primary finding, again, from the abstract, supplementation with omega-3s did not result in lower incidence of major cardiovascular disease or cancer than placebo. So, negative study, and this is the media coverage. Here's from Time magazine. Vitamin D and fish oils are ineffective in preventing cancer and heart disease. Eating more fish or taking omega-3s can cut a heart attack risk. So here's the opposite result reported from CBS versus the New York Times. Here, fish oil cuts heart attack risk. Vitamin D and fish oils disappoint. They didn't work. So the press is giving two different reports because they're looking at two different outcomes. So here is the actual data from the study, the omega-3 group, the placebo group, and the number of people with an event. And then over here is the hazard ratio, the relative risk. And if you look at their primary endpoint, major cardiovascular events, it was 8% reduced, 0.92, but not statistically significant. So that's what they based their outcome on. But if you look at one of the components, total heart attacks, total MIs, a 28% reduction in total MIs from the omega-3 treatment. There was no effect on stroke, no effect on death from cardiovascular disease in this study, primary prevention, but there was a reduction in risk for heart attacks. So because this wasn't changed and because this wasn't changed, the primary endpoint wasn't changed, so there was no effect. But there was an effect. You just have to look for it, and you look at and you see very clearly that there was an effect on heart disease. Other secondary endpoints that were pre-described, pre-planned, so this is not just going fishing. PCI was reduced by 22%. Total coronary heart disease was reduced significantly, and death from MI was reduced significantly by the omega-3s. But this is called a negative trial. It's called a no-effect trial. But the evidence from the study itself says, yeah, it had benefits. You just have to look in the right places and ask it for the right condition. So again, despite negative conclusions, I think this is a successful trial. Now, reduce it. Nobody has to make any excuses for this one because this was very good. This one worked out well. Randomized trial, again, this is the one that was a pharmaceutical trial. 8,000 patients, and everybody was on statins, so their median LDL cholesterol, 75 milligrams. What is that, about a 2, roughly, 2 millimolar? So LDL cholesterol was well controlled. Median triglyceride levels of 216, so that's 1.5 or something. Millimole, and had to have a history of cardiovascular disease or diabetes. So these are very much a secondary prevention study. The treatment was EPA ethyl esters, so just EPA. This stuff is called icosapent ethyl, is the name, the generic name of the product, but it really is just EPA. Amarin is the company that makes it, about a 5-year study. Major adverse cardiovascular events, again, a composite endpoint, but this time the composite endpoint actually showed the benefit. If we look at over the 5 years of the trial, this is the number of patients with an event in the placebo group and in the EPA group. And you can see that starting in about 1 year of treatment, there was a divergence in the curves. The EPA group had less and less events over time, such that at the end of the day, 25% lower risk for the primary cardiovascular outcome in this study. So this was a strong evidence that omega-3s can help. And here's a headline from it. Fish oil heart medicine, rarest of drug breakthroughs. Being able to have a product that's relatively cheap, few side effects, and is essentially a natural product, just concentrated in a pill, is a big step forward. I should note that I think the most important reason that this study was positive was right here. That was the dose, 4 grams a day. So that's 5 times the dose of the other studies that we've looked at, which you gave 840 milligrams. So when you give 4,000 milligrams a day, even if it's only one of the 2 omega-3s, you get a good benefit. So I think, and there's a new study going on now called Strength that's going to be reported out at the end of this year. That's 13,000 patients, essentially identical to this study, except it's with an EPA plus DHA product at 4 grams a day. And that one should also be positive, I'm assuming, and there should be more good news for the omega-3 role in cardiovascular disease. So what do we have? A brand new meta-analysis. Every time a new study is published, you get a whole set of meta-analyses done. This one just came out this year, mid-year, from the group that did VITAL. And they reported whether you're talking about risk for myocardial infarction or risk for CHD death, there's a statistically, even without reduce it, without the very successful trial. They left that out. That's down here. But without that study, there's still a statistically, here's the study, right, reduce it, an 8% statistically significant reduction in risk for people who got omega-3s versus people who didn't. So the evidence is now swung back to omega-3s are favorable. And that's the conclusion from this meta-analysis, lowers risk for MI, CHD death, total CHD, CVD, and total death. So it appears to be related to dose, and that makes sense. So once again, another headline, fish oil story rises to the top. Now it's now it's good again. Next week a new study comes out and it's bad again. And it's been a roller coaster for many years here. European guidelines are still focused on the effects of omega-3 on triglycerides. There have been recent changes in guidelines to say that omega-3 shouldn't be used for reducing risk for cardiovascular disease, but those guidelines were agreed upon before these 3 new trials came out. So if it was me, we'd be back at the table changing guidelines again. Again, this is from the guidelines from ESC and EAS for high-risk patients with triglycerides in this range. Despite statin treatment, omega-3, 4 grams a day should be considered. So this is from and they call it icosapent ethyl. Again, that's that pure EPA ethyl ester. And their recommendations are, of course, replace animal fats and dairy fats with vegetable sources, and polyunsaturates may reduce, and here we're talking about omega-3. And again, other guidelines here from a couple years ago, in the lipid-lowering nutraceuticals, omega-3, EPA, and DHA represent a valid nutraceutical to reduce triglycerides. That's fine. I think it's more important that they reduce cardiovascular events than triglycerides. So summarizing heart health, beneficial effects on many systems of the body, particularly the heart. Higher intakes than normal are needed to achieve cardioprotective levels. There really aren't any safety concerns with omega-3. You can measure omega-3 levels using the omega-3 index test. I brought one of our little blood collection kits. They look like this. These are available through our website in Lithuania. If people are interested in that. And omega-3 fatty acids do work to reduce risk for cardiovascular disease. It's just a function of dose, which should not be a surprise to anybody. Patient type, formulation, duration of treatment. Now let me skip quickly for a couple other areas to the very beginning of life, where omega-3s also play a role. Here is prenatal development. Of course, the brain itself is got a lot of DHA in it. It's very important for normal brain and eye function. So people have looked at many studies given pregnant women omega-3s, hoping to see benefits in the baby or in the mom. And as they've done these studies, they've always tracked when the baby was delivered, premature, not premature. That's part of the study. And it turned out if they look back on 80 or 70 different randomized trials of omega-3 in pregnancy, 20,000 women, they found that, and this is a Cochrane review published in 2018, they found that giving omega-3, particularly DHA, during pregnancy was associated with an 11% reduction in risk for preterm birth, which is birth before 37 weeks, and a 42% reduction in risk for early preterm birth before 34 weeks, and low birth weight, 10% reduction in risk, just for giving DHA during pregnancy. Which was somewhat of a surprise. That really wasn't the primary endpoint of all these studies. But they found it, and it's held up very well. In fact, they said one of the most unusual things I've ever seen in a scientific paper. Nobody ever says, we don't need more studies. You always say more studies are necessary. But after this Cochrane review, they said there are more studies comparing omega-3 to placebo to establish a causal relation in preterm birth are not needed. So remarkably, there is a benefit that's been seen in that phase of life. We have developed we published a paper recently. After we developed a new blood test, we can now measure using the same blood kit, we can measure a pregnant woman's red blood cell DHA levels. And so we think that measuring DHA in pregnancy would be helpful so you could know when you're at risk for premature birth. What we have here is if this is the omega-3 index, the DHA level, or prenatal DHA, if you have a level roughly of above 5%, and we'll say that's your risk of 1, if your omega-3 level is down around 3%, your risk for preterm birth is about 10 times higher. So the difference between a red cell DHA level of 3% and 5% is 10 times the risk for premature birth. So this is again, a test that I think hopefully obstetricians will eventually use. And this is a test that can be done at home. So this doesn't require a visit to the doctor necessarily. So mom can know what her DHA levels, and if they're too low, she can simply take supplements or eat more fish to increase it. The omega-3s given during pregnancy also have a benefit in the child afterwards. This is a study that looked at cord blood omega-3 levels and a diagnosis of wheeze or asthma, so pulmonary problems, wheeze or asthma at age 6 to 7. A couple of studies were pooled. We can really just look at the purple bars, and this is relative risk. This is the risk for having asthma or wheeze at that age as a function of having a 1 standard deviation higher omega-3 level in cord blood. So if the baby's level was 1 standard deviation above normal, above average. In this case, there's a relative risk 0.6, so that's a 40% reduction in risk for wheeze, about a 50% reduction in risk for asthma at that age if your blood had high omega-3 levels at birth. So this is obviously an argument for moms to get the right amount of omega-3 in their diet while they're pregnant. I'm going to skip that one, it's too complicated. This is an interesting one, effects of cod liver oil, study done in Norway. They're looking at the effects of giving cod liver oil during pregnancy and lactation on IQ at age 4. And they found that actually the group that got cod liver oil versus the placebo had somewhat higher IQ at age 4, again, higher mental processing scores when mothers were supplemented with long-chain omega-3 from cod liver oil. So this kind of study has been replicated in other settings. So there is something about brain development of the baby when you get more omega-3. How are we doing on time? Okay. I haven't seen this yet. So that's a good sign. Also in the area of neural development for babies, DHA intake and measurement of neural development. In this study, called the Diamond Study, 122 term infants. So this is now after birth. Now we're talking about what do you feed the baby after it's born. Okay. Randomized to 1 of 4 different infant formulas for 12 months, a control formula, a low DHA, middle DHA, and high DHA. All of them had some arachidonic acid added. And they were followed for developmental outcomes at 18 months and at 6 years. So they looked at them for a long time. Here are the different acronyms for the different kinds of neural developmental tests. I'm not an expert in this, so I'm just trusting the authors know what they're doing. What they found was on this particular scale, a multidimensional intelligence scale at 6 years of age, the kids who got the formula when they were 1 year old, or up to 1 year old, had significantly higher verbal IQ, non-significantly, but a trend toward a higher performance IQ, trend toward higher processing speed, full-scale IQ, 0.69 p-value, pretty close. It's about a 6-point difference in IQ as a function of taking DHA, and this is pooling all the DHA groups together. So getting DHA in a infant formula was important for brain development, which is really why all infant formulas now can be supplemented with DHA. The DHA comes from an algal source, not from a fish source. 3 years. So at 3 years, there was no difference. 4 to 5 years. So it's out here where you start seeing the difference. Here's the control group. This is one of the dimensional scores. Control group is here. Then the low, middle, and that's the high DHA group. That's kind of an interesting finding that there seems to be a level of diminishing returns for sure. So people are now targeting about 0.64% of DHA in infant formulas. And again, another test that they did in this group, DHA supplementation increase. This is the different levels of DHA supplementation. Here's the score. Again, infant development score. The higher the DHA dose, the better in this case. So they summarized data from this trial suggest benefits on several measures of cognitive development in early childhood for the first year of life. Long-chain PUFA supplementation in infants improved performance on several assessments of executive function, verbal measures derived from standardized tests 5 and 6 years old. And then it looks like it has a lasting effect on cognitive function in childhood. So another reason to consider the importance of omega-3 fatty acids. Mental health, we've done some studies in this area, as have others. Once you have enough studies to do a meta-analysis, you know there's been quite a bit of interest. This is a study in attention deficit hyperactivity disorder in children. So in this study, there's a question about blood levels. They took kids who have ADHD and controls, they measured blood omega-3 levels, and they found overall that ADHD kids had significantly lower levels of omega-3 in their blood than controls. Obviously doesn't mean that omega-3 is causing it, but it suggests that there may be some benefit to supplementing with omega-3. And interestingly, when they actually do randomized trials with omega-3 in ADHD children, they found statistically, again, a meta-analysis, decreased symptoms, a significant benefit in symptoms in kids that were given omega-3. So there's something about it at this stage. So it's in utero, first year of life, as a child, when we've talked about, of course, heart disease for adults. But then interesting effect here was seen in a prison population. So based on the idea that omega-3s might affect cognitive function and aggression, they looked at aggressive behaviors and attention deficit in adults who were prisoners in a couple of prisons in Australia. 136 male prisoners. They used some metric to quantify aggressive behavior, and then they were given, I think, this was just looking at blood levels. This is not the intervention one. So what they found, this was the omega-3 index distribution in this population, and again, the average level is around 4 to 5%. Very few of them up in the high levels. Then they linked omega-3 levels with hostility scores, and they found all the yellow ones are statistically significant benefits associated with having a high omega-3 versus a low on hostility and aggression in prisoners. And again, these scales are things that I don't know much about, but it suggests that there may be a benefit to giving omega-3s in prisoners. This is anxiety now. It's a different outcome. And again, meta-analysis, all these trials that have been done giving omega-3 or placebo to people with anxiety disorders. And on the whole, there was an average benefit, statistically significant benefit. It's hard to know exactly how to put a number around that, but there was a net effect on anxiety or ability to resolve anxiety. And we've seen depression, a study we did when I was in Kansas City, looking at depressed heart patients, 118 versus 641 non-depressed patients admitted with an MI. We found omega-3 levels were significantly lower in the people who were depressed versus non-depressed, and that's been seen before. Now let's move on to the end of life and near the end of the talk. So now we're looking at dementia and Alzheimer's disease. This is a very interesting study done in the Framingham population, where about 900 people, participants in this cohort study, average age 76 at the time the blood was taken. They had the omega-3 levels measured, and they measured a specific fraction of omega-3 in the plasma, the phosphatidylcholine, DHA, but it correlates well with red cell DHA. They tracked the incidence of dementia or Alzheimer's disease for 9 years after that time, and they asked the question, is there a difference in risk for developing Alzheimer's disease or dementia as a function of omega-3? And what they found is if they looked at the individuals in the top quartile, the highest quartile of omega-3, so 25% of the population, their risk for developing dementia over this roughly 10-year period was about 50% lower than people who had omega-3 levels from the 75th percentile down to the lowest levels. So having a high omega-3 was at least associated with a lower risk for developing Alzheimer's and dementia. It's a very, very difficult disease to study with randomized trials because it's so long in developing, but people are working on it now. And again, study that we did also in the Framingham population, we looked at brain volume by MRI scans in a fairly normal, healthy population in Framingham at age 66. We found, these are all the covariates and the p-values, but we found that total cerebral brain volume was associated with the omega-3 index, a higher omega-3 index, a larger brain volume. And we found when people did memory tests, executive function or abstract thinking tests, a lower omega-3 index always meant poorer function. So we, again, linking omega-3s to cognitive function in that age. We concluded here that the findings of a lower brain volume in those patients who had an omega-3 index under 4%, that was kind of we looked at the highest quartile. The lower brain volume in these people represent a change equivalent to about 2 years of structural brain aging, meaning if you're 66 years old and you had an omega-3 index under 4%, then your brain was about the size of somebody who was 68. In other words, 2 years younger brain size if you had, 2 years older brain size if you had a low omega-3 index. I'm trying to say that right. Dementia, we found this as well. We're looking at cases, and this is in the Women's Health Initiative, where we're looking at the effects of one standard deviation higher omega-3 index as a function of whether they develop dementia or not. 9% reduction of developing dementia in Women's Health Initiative. No effect on mild cognitive impairment. And brain volume, again, this is another study we did in the Women's Health Initiative. We looked at brain volumes and we looked at hippocampal volumes. Measured red blood cell levels correlated with the brain dimension. Found a positive correlation between the omega-3 index and total brain volume and hippocampal volume. So this is the omega-3 index along this axis, and this is the size of the hippocampus, which is the primary memory site in the brain. So the higher the omega-3, the bigger the volume of the hippocampus in these women who were, again, in their 70s. So that was better for them. So hippocampal atrophy can, to some extent, predict which patients with mild cognitive impairment subsequently convert to dementia. So converters have an enhanced rate of hippocampal volume loss. So maintaining the size of the hippocampus can help slow memory loss in this view. Okay. DHA and vision, I think this is the last health condition we deal with. And thank you for hanging in there. Most of you are awake. I'm impressed. So we're looking here at, there's an authorized health claim that DHA can contribute to maintenance of normal vision, taking at least 250 milligrams, which you need more than that. We'll look at a couple of studies, one in the area of glaucoma, so intraocular pressure. This is a pool analysis of 2 different randomized trials that were done studying the effects of omega-3 on dry eye disease. About 100 people involved got about 1,500 milligrams a day of EPA and DHA for 12 weeks. Actually takes about 16 weeks to get a new steady state on the omega-3 index, because that's how much time it takes for red cells to replace. They were looking at the effects on intraocular pressure, which is, of course, the pressure on the inside. Glaucoma is one of the results of high intraocular pressure. And they found that over that 12 weeks of period, the group that got the omega-3s actually saw a reduction in intraocular pressure compared to the placebo group that saw a significant increase. So there was a significant benefit. And this hasn't been studied much. So this is one of the new areas where omega-3 might have a role. Again, in the idea of tear osmolality, this is dry eye. disease. In this study, if the tears have a high osmotic or osmolarity, meaning there's a lot of dissolved minerals and salts in them, the tear is not going to give you a good film on your eye, so you'll have dry eye disease. So people measure tear osmolarity. Again, a placebo-controlled trial, about 100 patients, 2.7 grams of EPA DHA, so it's a good-sized dose. They measured, again, molarity. Then they measured these other metrics, including the omega-3 index of eye function. And what they found was, this is the placebo group. Over time, the change in the tear osmolarity. Here's normal levels down here on this line. The people who got the omega-3s had a significant reduction in osmolarity, meaning the tears were more fluid, there was less minerals dissolved. And so there was a better outcome for dry eye. They also looked at what's called TBUT, which is tear breakup time. So how fast do your tears break up once you blink? This is measured, again, the longer the tears stay intact after a blinking of your eye, the less likely you are to have dry eye syndrome because the cover is protected. And so going from a baseline omega-3 index of 4.2% to 7.2%, the omega-3 group had an increase in tear breakup time, which is a good thing compared to the placebo group. So they found, again, tear breakup time was significantly benefited. Ocular surface disease index, which is another metric of all this. Matrix metalloproteinase peptidase 9 is an inflammatory marker. It was reduced significantly. And, of course, the omega-3 index went up because they were given omega-3 fatty acids. And dry eye disease, here there's 17 trials with 3,300 people. If the estimate is here to the right side, it favors the treatment, so there was significant benefit on dry eye disease and omega-3 supplementation trials. So I think that we must be close to the end. We are close to the end. Thank you for your attention. This is actually the other side of Mount Rushmore. The state I come from has Mount Rushmore with the 4 presidents. None of the presidents are current presidents, I should mention. Our founding president, this is the other side of the mountain, but not really. Thank you for your attention.
Thank you, Professor, for a very comprehensive and elegant talk. While we are waiting for questions from the audience, I would like to invite for discussion our experts. We are honored to have here Head of Clinic of Cardiovascular Diseases, Professor Aleksandras Laucevičius. The professor has profound knowledge and very long research experience in field of cardiovascular prevention in Lithuania. So please, Professor, maybe here. It's my pleasure to invite Vilnius University Professor Žaneta Petrulionienė. She is an expert in lipidology, so please join us for discussion. And also, it's my pleasure to invite Associate Professor Edita Gavelienė. She is Doctor Dietitian from Vilnius University, and I believe that she knows everything about nutrition and nutritional therapy. So now, please ask questions. Please.
So the question was about having mercury, essentially, heavy metals in dietary supplements. The short answer is no, partly because just the process of getting the oil out of a fish removes the oil from the protein in the water portion. Those minerals are not soluble in fat, in lipid. They're soluble in water. So right there they separate, plus all the processing that any supplement goes through to remove off flavors
and oxidation products and all these other steps continues to remove anything that would be there. So that's not a problem. Oh, so do omega-3s basically help you lose weight? Is that fundamentally the question? Burn fat faster? I don't know of any evidence for that. There really is very little evidence that taking omega-3 supplements reduces body weight. So there are in hundreds and hundreds of trials where they've given fish oils, they haven't reported on a reduction in body weight. And you think you would see it. So whether it changes how you burn fat, that I'm not aware of any data on that, but just body weight changes don't happen. I wish they did.
Vitamin E and polyphenols are like antioxidants in fish oil. Fish oil is very unstable, as all polyunsaturated fatty acids. So this is a problem of quality of medicine which we give. That it could be that we are giving not vitamin, not DHA, EPA, or just other acids. What about stability of these products?
So the question's about, because omega-3 are polyunsaturated fatty acids and they can oxidize easily, how do they get, are the supplements and the drugs that are made from them, are they stable? Do they really have oxidation products? Is that kind of the question? Something like that. Yeah, I think the short answer again is because fish oils have been, the technology of processing fish oils has improved and improved and improved over the years because people are making it so often, and they work very hard. Once it's in the capsule, the liquid oils is a different question, but for encapsulated oils, once it's in the capsule, it's completely, no oxygen can get in it. And so if oxygen is excluded for the whole process, and they usually use nitrogen or argon as the atmosphere, they completely remove any oxidation products. And for liquid oils like cod liver oil, that's also processed nowadays in a very clean way to remove oxidation products. So, I mean, they taste, if the oxidation products are there in any significant amount, the oil will taste terrible and nobody would take it. So they have to get rid of it. Right, so it's a good question about vegans who don't eat fish. Some vegetarians don't eat fish, and so how do they get omega-3? There is, of course, some synthesis from alpha-linolenic acid, and it's certainly enough. It's enough to keep a person alive, obviously, because these people exist. Right? They don't die for lack of, right? And they can reproduce and have babies without taking any EPA and DHA. But their levels are quite low, and there may be health risks to those people. To raise omega-3 levels in those patients, there are products from algae. Certain single-celled species of algae produce EPA and DHA in their oils, And those are really at the base of the marine food chain. So there are many companies now that are growing these algae and harvesting the oil and putting it in capsules for vegans and vegetarians. So you can get EPA and DHA in a supplement, not from fish.
I would like to ask our Professor Aleksandras Laucevičius, what is your opinion about the role of omega-3 in cardiovascular prevention?
I can speak as a doctor, as more than 15 year user of omega, so I can speak about pluses as a doctor and maybe some doubts as a patient. So I think the main thing is that the doses we're using are it's not more than 1 gram, it's 1 capsule. So for me, it's always not clear. Does it make sense to use these small doses for primary prevention? Or it will not work, it's just wasting of money and time? That is one question that I have. Another question, if I use 2 or 4 grams, let's say, of PUFA, so is it safe, especially in cardiovascular patients who go, let's say, for catheterization, for stenting and so on, and use double antiplatelet therapy? Myself, I have very bad experience with bleeding when using high doses of PUFA. And in recent time, operations I had, in every operation, until I understood this and convinced our hematologist, I have bleeding complications. And these are not platelets, these are most bleeding and coagulation time. So very, very long bleeding time. So for me, other question would be how safe it is to use 2-4 grams.
Yeah, those are great questions. Number one, I think, pending the safety question, primary prevention probably should use at least 2 grams of EPA DHA. It's never been tested. The whole reason people use 1 gram of omega-3 is because of the GISI Prevenzione study in Italy in the late 1990s, and that was very successful. So almost all the studies modeled after that one. And nowadays, as medical care, heart care has improved over the last 20 years, there's less and less additional benefit visible from that dose. So I do think higher doses are important. As to the bleeding question, it's a controversial one. We did a review recently of looking across studies where they report bleeding complications in patients who are on other anticoagulant medications or on platelet inhibitors or on omega-3, and at least the reports of clinically, what they call clinically significant bleeding, there was no increase. And we also did a study in patients who were having open heart surgery, where we gave them a large dose of omega-3 for 2 or 3 days beforehand to try to prevent atrial fibrillation post-surgery. That was the goal. It didn't work. But we also looked at the bleeding complications reported in those who got omega-3 treatment and those who didn't. And there was actually, in that study, which is 1,500 people, there was less bleeding, less need for transfusion, that way, less need for transfusion in those people that actually got the omega-3 treatment than the other one. So I think it's I certainly can't contradict your clinical experience, no doubt, but there is some controversy as to whether there may be more bleeding, whether it's abnormal bleeding or what is normal bleeding, I guess is a good question in that regard.
Maybe Professor Petrulionienė, do you have any questions, comments on the topic?
So I think that today we have a great event. Thank you, Professor. Excellent lecture. We were waiting for this new data because it's very important for cardiologists and for all of us, especially for cardiologists. I would like to remind one big study, GC Prevenzione, as you all remember. So there were after my patients, and it's very important for us, should we prescribe omega-3 fatty acids for all patients in secondary prevention? What would be the dosage, 1 gram or maybe more? And another question, how do we can react to newest guideline, Dyslipidemia 2019, where is only pure EPA recommended, because we do not have pure EPA in Lithuania. And there is mentioned only increased triglycerides only. So how do we have to react, and what could you say about DHA and EPA together in one capsule? And the last question, the minimum dosage and the maximum allowed, 4 grams, 5 grams, and side effects if we use more. Thank you.
Do you remember all those questions?
Yes.
Okay, I'll try. So I do think the GC Prevenzione study did say 1 capsule, and that was the beginning of the good evidence that omega-3 helped. I think that's, in patients today, that's not enough. I think background therapy has improved. Pharmaceutical therapy and medical interventions after heart attack, acute angioplasty, these have all changed risk for subsequent events. So I would think 2-3 grams a day would be safe and effective. The EPA only product, right? If there are any guidelines there for that, because that's the only study that's been done, and it was effective. But it doesn't mean that an EPA and DHA product would not be effective. It's just EPA was. That's what they tested. Again, at the end of this year, there'll be a bigger study, the same design as Reduce It with EPA plus DHA. 4 grams a day, and it'll be 4 grams of a, not more, no. But that is it's not an ethyl ester. This is a free fatty acid product, so it's absorbed even better. So I'm expecting that to be positive. And so then we'll have to say EPA and DHA or EPA alone will be effective. I would not assume that EPA plus DHA is not effective just because somebody's guideline talking about one trial. People have very rarely tested higher than 5 grams. I mean, in the very beginning, when we started studying, we were giving people 25 grams a day of EPA and DHA because we didn't know how much. This was kind of an Eskimo dose. That was the idea, very high dose. And we saw triglyceride lowering. We saw bleeding time increase, but not any more than aspirin. So that there was safety there, but there's just a practical limitation. The pills are big. To get 4, 5, 6 grams, you need 4, 5, 6 pills, and that's unless you're doing some kind of liquid. So we don't know much of anything nowadays about cardioprotection from that. Is there anything else?
One more question. My omega-3 index is only 5.11. I know exactly. I did it. So how often should we repeat this index? And could you please comment a little bit more about the omega index, complete index, maybe basic and complete? And do you recommend for all sitting in the audience to know the omega-3 index?
Yeah, so you're 5.11, huh? Well, you're average. Okay. I'm sure you're above average in many other ways, but so how do you affect it? It takes about 16 weeks, 4 months for all the red blood cells to be replaced. And so we've seen that it takes about that long. If you change your dose of omega-3, I wouldn't measure it again for about 4 months. And then you should be at a new steady state, whatever it is. What was the other part of that?
Would you recommend?
Oh, do I recommend? Yeah, I mean, people ask me, well, who should be tested? And I think, who shouldn't be tested? I mean, I don't know why anybody would not want to have an It's like for cholesterol, we recommend, everybody should be tested as they're a child and adult. It's the same thing, except I think you should probably start earlier. You should start with a mother, optimally. But I think it makes sense to know your omega-3 level because it's so, at least conceptually, easy to change it. And why not do the best you can in every area that you can? So, the practical question, you would measure omega-3 index in people at increased risk for cardiovascular events. That would be a simple place to start. But in many countries, that's everybody.
So how do you achieve this?
Thank you for wonderful lecture, yes. And yes, my index was 8 and 11. That's, yes. Thank you. Because I think that for general health, it is not only omega-3, it is necessary other things, and physical activity not in the last place, and all things what we are putting on our plates. But I want to ask you, is any differences in age according omega-3 index? Because maybe according this thing, it is some differences in doses.
Yeah, there is. Right. So there is an age relationship with the omega-3. Actually, it goes up with age. It's higher with older. Sorry, is that why you're so high? Yeah.
I recognize that.
No, and nobody really knows why, but every population we've looked at, the older people, now it could be in many populations that older people are eating more fish. Maybe not. The other explanation for it is that people who have low omega-3 levels die. So what's left have an average higher omega-3. So it's the attrition of the susceptible, they could call it. But the mechanism of that, we don't know. And we really don't know what target levels are for children at this point. And we just need more data. The 8% really seems to work for brain health for adults and for heart health, but I don't know for other groups.
One more question about combination. Use of combination, statins plus omega alone, omega plus statins plus physical activity, omega plus physical activity. Wow. Does it has any influence on index or not?
No, statins don't really affect the omega-3 index per se. So whether you're taking a statin or not is not going to affect what the omega-3 index is. Exercise, inside the realm of normal people's exercise doesn't make a difference, but when we've studied elite athletes, they tend to have a low omega-3 level. And it could be because they are actually burning it for energy. That's our hypothesis. We actually studied dogs in the Iditarod dog sled race in Africa. Alaska, it's the A word, right? In the Iditarod. So, and these huskies actually started out with higher omega-3s. At the end of the race, they were lower. So the omega-3s apparently respond.
Does it mean if we are, let's say, focusing ourselves on physical activity, it's a big need to have supplementation?
The benefits of omega-3 in the exercise field are apparently not so much in enhancing performance as in enhancing recovery. It accelerates recovery, less soreness of the muscle in studies where they've given omega-3, but it really doesn't seem to increase performance per se.
one more question about arthritis, rheumatoid arthritis. I know that the patients who have pain that is not related to infection in rheumatoid arthritis, adding omega relieves the pain. That's one thing. Maybe you can give a comment. And there was combined drug supplement, I think, omega and glucosamine chondroitin in one capsule.
Oh, I'm not aware of that combination, but it sounds promising. It sounds like a big capsule.
In state it is available, but it's quite expensive.
Yeah. And the studies where arthritis pain has been improved used probably 5 or 6 grams of EPA, DHA, a big dose, liquid drink of omega-3. And so there are not many studies like that. They've been done in Australia. And so it may affect arthritis, but it might take a big dose to do it. Yeah.
Could you please comment on possible side effects of omega-3 and possible interactions between commonly used cardiovascular drugs and omega-3 supplements?
So interactions between cardiovascular drugs and omega-3 at high dose. I think we're talking at 4 grams a day. Again, there really are no, perhaps outside of the area of bleeding, there certainly could be some implications there for high omega-3 making blood more thin. But that's the only one. It doesn't interact, as far as I know, with any other drug, adversely interact with any other drug. And other than the concern about bleeding, you have people report gastrointestinal upset. You get a burp, a fishy burp, which is hard to call that. It's a side effect, but it's not a health risk. It's annoying, but that can be addressed by taking really pure oils, taking them at bedtime. That helps reduce that. So that's really all we know, I think, about adverse effects of fish oils and drugs.
Okay.
I don't think that bleeding from gastrointestinal or something like that is very important, but the question is if the patient goes on quite serious surgery and uses 4 or 5 grams, how long has he it lasts until it doesn't work? So I thought about 2-3 weeks, but
longer than, yeah. So this is a good point, because I've seen many situations where someone's going to surgery next week or next day, and the nurse goes over the list of medications that you need to be off of, and one of them is fish oil. But it's going to take 2 or 3 months to completely wash all the omega-3s out of all your cells. So it's kind of a silly exercise to try to stop it, because it's not going to change anything in the very near term. But again, there are not that many people taking 4 or 5 grams a day of omega-3. But if they are, I'm sure that's
in the future they will take.
If everything goes
After
well.
your lecture, I think.
So my question would be, in the pharmacies in Lithuania, we have up to 100 different fish oil supplements and so on, many. The main criteria, 1, 2, or 3, how to choose between them. Maybe purity, dose of EPA, DHA, because, every day pharmacists, they're offering different brand names.
Right, and to me, it's a matter, I like to see how much omega-3, EPA, DHA per serving there is. Because you can buy very cheap pills that have very little omega-3 in them. And you need to take 8, 10 capsules to get a good dose. And there's other pills that are much more expensive because they've concentrated the omega-3s. There are other forms besides pills. Cod liver oil, again, you can get. So we think roughly 1,500 milligrams a day of EPA and DHA will take a person from a 4% to an 8%. And that's about 7.5 milliliters of cod liver oil. So that's a pretty easy way to do it. It's easier to do that than swallowing 7 pills. But still, it's very hard to know about purity per se. And there's nothing on the label that will tell you. You just have to use trusted brands that have been around a long time, who are very concerned about their name and their reputation, and they make good quality stuff. So it's hard. I know it's hard with so many options.
In United States, in GNC, I always use this from GNC, is triple strength in one capsule. It's not bigger than usual capsules, and it's 1.5 gram of combination of PUFAs.
So is it a combination of it's all omega-3, EPA? Okay. Because they do make, omega. Just wrong. That's a big pill. 1.5? Well, it's bigger than 1. But yeah, I mean, that's another way of doing it. There are products. I've seen some that are 1.4, 1,400 milligram of oil with 980 milligrams of DHA and EPA. That is the same kind of idea. But those are, again, they're highly concentrated. They're fairly expensive. But you can take 4 of those a day and get roughly 4 grams. And that's pretty much what a dose of Vasipa will do.
So we have time maybe for 1 or 2 questions from the audience. Please do not hesitate, because as a bonus, you will get an opportunity to check your own omega-3 index. Please.
Regarding the cardiovascular thing, I mean, young people tend not to use supplements. Is there a certain age they need to start to look over?
Well, it's like, when should you start to exercise? It's kind of that kind of question. The benefits of exercise really show up later in life, so maybe you shouldn't start till you're 50. But that doesn't make any sense. It's really, I think, it's like the evidence from Japan. Having omega-3 levels of roughly 8 or 9% from birth, essentially. If you get them from your mother, and then you start adopting a Japanese diet as you grow up, that's associated with a 4 years longer lifespan. The Japanese have, compared to the United States, the Japanese live 4 years longer on average, despite all those other health, smoking, high blood pressure, So maybe that's a lifetime of omega-3, being in a healthy zone. I don't know we can test it, but that's what makes sense to me, that there's no reason not for a teenager not to have a healthy omega-3 level.
Some more questions.
We are talking about EPA, DHA. The physiological effect is different. For example, as I'm a pediatrician, so in children we are talking about DHA, about the amount of DHA, etc. Now when we are talking about the PUFA, it's like we are talking about the antibiotics. Nevertheless, it's penicillin, amoxicillin, etc. So maybe it should be in the future that pure EPA, pure DHA in such strict conditions and strict restrictions, etc.
Yeah, I think so. For those of you who didn't hear, probably in the future, because EPA and DHA do have different properties, different effects. We may have pure. We've already got one pure EPA product. We will probably have, although I don't know who's going to make it, the DHA alone product. It's not been tested in large trials. I think that's probably true, and we will refine over the next 10, 20, 30 years, refine what conditions best respond to each one. But for today, I still think it's best to get both of them. They come together in fish naturally. They have overlapping effects. Both are anti-inflammatory. They have different effects on lipids. But I still think that the simplest thing to do is to aim to get both of them for now until we know better. I don't think you should just pick one or the other at this point.
Please.
Professor, I would like to ask some technical questions about intake of omega-3s and how it intake during the day. I read some articles that it is important in the morning during the breakfast because it's better absorption. Do you have some opinion about intake?
So the question is it best to take it in the morning with breakfast because better absorption? I don't think so. I think taking them with a meal, yes, but I don't think it has to be breakfast. It could be any meal. I've never seen anybody actually study the difference in effects of taking it at breakfast or at lunch or at dinner. Physiologically, there shouldn't be any difference.
So any more questions? Final one.
I would like to ask about omega-6 and alpha-linoleic acid and quantity of omega-3 and omega-6 that we should have. So do we have to forget about omega-6 at all, about vaccines, and what is the position?
Yeah, so I wondered if anybody would ask about omega-6 because they are commonly felt to be bad for us, and I don't agree with that opinion. I don't think one needs to take omega-6 supplements. I don't see any reason for that. But I think we need to maintain a healthy intake of omega-6 in the face of people who say we need to reduce our omega-6 intake, because I don't believe that that's good for our health. The evidence that we've seen lately from very large epidemiologic studies is people that have the highest levels of omega-6 in their blood are at lower risk for heart disease in the long run, and they are at lower risk for diabetes in the long run compared to people who have low omega-6 levels. So any advice to lower your omega-6, I think is counterproductive. I don't think that should happen. But I primarily think the most important thing is to get your omega-3 up. Omega-6 we can kind of just not worry about, in my point of view.
So, very final.
Professor, you briefly mentioned that omega-3 also acts on our endocannabinoid system. What would be maybe some additional benefits on that mechanism?
Yeah, the endocannabinoid system is a relatively new pathways, both in the brain and in other tissues. The CB1, CB2 receptors are activated. Actually, they're activated by the arachidonic acid-based metabolite, and the omega-3 metabolites don't activate them as much. It's a similar thing that happens in platelets with arachidonic acid and thromboxane, et cetera. So the omega-3s probably will damp down whatever the effects of the arachidonic metabolites are. How they're going to be, whether they're playing any role in the omega-3 effect in depression or anxiety or aggression or any of that, nobody has any idea. It's an exciting field, though, to see other metabolites that have biologic activity.
So time is running fast. I think we should finish. So thank you, Professor Williams, for very interesting lecture. I would like to thank our experts also for very good discussion. And I would like to invite you all to the second floor, just opposite our first auditorium, for a cup of coffee and some snacks. And please do not forget to take your certificates. So thank you for attention.
Not really speaking, not 1 gram, not 1.5, but let's say 2 grams.